Hello everyone, I am Dr. Meet Chaudhary. I am Assistant Professor in Cardiology at UNMICRC Institute of Cardiology and Research Center. Today we are going to discuss about carotid artery, its anatomy, carotid artery stenting, its indication, procedure and procedure related complications and other evidences. So it will be discussed under this all heading. Initially we will discuss about anatomy and carotid artery disease indications, prevalence indication for the stenting and carotid endarterectomy versus carotid artery stenting, as well as procedural aspect of carotid artery stenting. Then ultimately we will discuss about some complication and a few of the studies. So the anatomy, as you all know, that aortic arch has three branches, where there is a right brachiocephalic artery, left common carotid artery directly arise from aortic arch, and left subclavian artery. From right brachiocephalic artery there are two more branches of right common carotid and right subclavian. There could be some variations that we will discuss ahead in the presentation, and these are the aortogram that are showing the three branches of aortic arch. So common carotid artery arise at the level of thyroid cartilage of the fourth cervical vertebral level, gives two terminal branches. One is external carotid artery, another is internal carotid artery. External carotid artery supplies the blood to the face and head and neck, that we all know, and gives branches in the neck region, while internal carotid artery goes directly into brain and supply ipsilateral side of brain and cerebral. Yeah, and it also take parts into forming circle of Willis. So how to identify it is internal carotid artery do not give any branch in neck, while external carotid has multiple branches. So these are the digital subtraction angiography image, DSA images of common carotid artery injection. The one on the left is the lateral view, where you can we can see bifurcation more clearly. Another one on the right is the AP view, where bifurcation of the common carotid artery is not that much clear. As one can see, the internal carotid artery do not give any branch in the neck. And we take lateral view, we can take AP view. Another is ipsilateral oblique view. Like for the left common carotid artery, we can take LAO view. For the right, we can go somewhat RAO, around 30-40. So that is how we define on DSA. These are the segments of the internal carotid artery that take from the C1 to C7. That is 7 segment. Our main concern will be for extracranial carotid artery. For carotid artery stenting, our main concern is for C1 segment. So till it enters the skull. After that, there are more 6 segments, and these are the all anatomical aspects. So this is also the same segments of the internal carotid artery, and their designation and their respective anatomy. And the internal carotid artery from both the sides, giving branches like anterior cerebral artery and continues as middle cerebral artery. It also gives branch to posterior cerebral artery in form of posterior communicating artery, and this is how it forms the circle of Willis. Circle of Willis will be formed with bilateral ICA, then anterior cerebral artery and posterior communicating arteries, which communicates with posterior cerebral. The internal carotid artery, after giving these branches, continues as middle cerebral artery. So on angiography, carotid angiography or digital subtraction angiography is actually gold standard to define internal carotid as well as for external carotid, and for extra as well as intracranial carotid artery disease. So we have to take multiple projection, as I have already highlighted, that we take straight AP view, or we can take lateral view, or 30-40 degree ipsilateral angle oblique view to open up the bifurcation more clearly. One should also take a Townes view. In the Townes view is actually a PA cranial view, where we see there is petrous bone or petrous ridge come at the base of the orbit. In this view, we can define the cerebral circulation more clearly, and we should take it as a baseline before any intervention and also after the intervention to compare. So we will discuss about carotid artery disease now. The prevalence of carotid among all the cases of the stroke, 80 to 85% of the strokes are due to ischemic causes, and rest are due to hemorrhagic causes. In these all ischemic causes, up to 25% of the strokes are related to cervical carotid artery disease, that is extracranial carotid artery disease, and majority 75% of the strokes are into anterior circulation, that is in the carotid artery circulation. Rest are in the vertebrobasilar system. So a big chunk of the strokes may be due to the carotid artery disease, the atherosclerotic disease, and that is what we have to address. And the carotid artery disease and its association with the CABG is like roughly up to 8 to 12%, that is up to 10% of the patient who was scheduled for CABG has asymptomatic but significant carotid artery stenosis. So more the severity, more likely these patients can develop the stroke. So, and those who have bilateral high grade stenosis have very high chances, like 25% incidence of perioperative stroke. So this is why the carotid artery screening is important before coronary artery bypass. How to define the stenosis is the stenosis that is more than 50% of diameter stenosis is considered to be significant, and those patients who has current symptom or symptoms within the previous 6 months are the symptomatic patient, while the asymptomatic patients are do not have any symptom or has symptom beyond 6 months. Indication for the revascularization either by carotid artery stenting or carotid endarterectomy are these two. For the symptomatic patient, we take cutoff of 50% to up to 99%. In totally occluded carotid artery, we generally do not do any intervention. So up to near total, so more than 50% to near total in such patient who are symptomatic and where the periprocedural risk of stroke and death during this intervention, risk of stroke and death should be less than 6% for symptomatic patient, and for asymptomatic patient it should be less than 3%. In such patient we consider the intervention for revascularization, either carotid artery stenting or carotid endarterectomy. So this periprocedural risk of stroke and death is defined by the institutional data. Like in our institute, how much patients with such revascularization procedure has some complications, and based on that we infer the data and then we decide this risk. So this slide shows the recommendation for carotid endarterectomy versus the stenting. So in asymptomatic patient who has stenosis in the range of 60 to 70% or more, in such patient if life expectancy is more than 5 years or more than equal to 5 years, or there is favorable anatomy, and one of the risk factor for high risk of stroke despite of giving best medical therapy, the best medical therapy in such patient is dual antiplatelet and or single antiplatelet or statin therapy, but and also controlling the risk factor like hypertension and diabetes. So despite that, if there is one feature that suggests that this patient can have high risk of developing a stroke, then we can go ahead with the carotid revascularization. Here carotid endarterectomy is given class 2A recommendation, while artery stenting is given class 2B recommendation. In those who have less than 60% stenosis or there is complete occlusion of the carotid artery, in such cases we only go ahead with the medical therapy, that is BMT, the best medical therapy. And symptomatic patient, the cutoff is 50%. If the stenosis is more than 50%, then one can go ahead with the carotid endarterectomy or carotid artery stenting, and the level of recommendation is class 1 for carotid endarterectomy, and for carotid artery stenting it is class 2A. But this is for average risk patient. in a patient who is undergoing coronary artery bypass, those who have left main disease, extensive triple vessel disease, severe LV dysfunction. In such patient, endarterectomy pertains more risk. In such patient, carotid artery stenting is preferable. So these are the high risk features that points when in an asymptomatic patient, in a asymptomatic carotid artery disease patient, when we are undertaking the option of optimal medical therapy. These are the features that pertain that this patient will be at a higher risk of stroke. So if one of these feature is present, then we can, even in asymptomatic patient, we can consider carotid revascularization. So these are imaging feature and clinical features. So for procedural aspect, those pre-procedural assessment is usually done with CT or MR angiography. It is better to do it beforehand because it can give better visualization of aortic arch. Many times there is anatomical variation in aortic arch which leads to difficulty in engaging the carotid arteries, and there are certain variants of the aortic arch that can make it very difficult and also give us a presumption that we will have to go with this particular device or this particular catheter to engage that artery. So in such the pre-procedural assessment with a CT or MR is essential, and cath angiography is ultimate gold standard. So these are the features where the patient is considered to be at a high risk for carotid endarterectomy, as I have already told. Those who have angina, those who have myocardial infarction within a few days, those who have coronary artery disease with left main involvement or extensive triple vessel disease, those who have LVEF of less than 30%. These are the patients who are usually undergoing coronary artery bypass. Such patients are actually high risk for carotid endarterectomy. Even if carotid endarterectomy is a class 2A recommendation, for these kind of patient, carotid artery stenting is actually better. So in our institute as well, we perform mainly carotid artery stenting before the CABG if it is indicated. And these are the patients who are high risk for carotid artery stenting. So these are the patient, like in patient with severe AS or very much calcific aorta, or there is certain aortic arch variant like type 2, 3 variant or bovine arch. In such cases, there is increased risk of atheroembolism because of too much catheter manipulation, and also bleeding disorder. All these are relative, you can say, contraindication, or these are the high risk feature for the case. In such cases, we can consider for carotid endarterectomy. So these are the variant of the aortic arch that I have already told you. There are 3 types, and it is based on the distance from the top of the aortic arch till the origin of the brachiocephalic artery. So if this origin is this distance is less, then it is more into type 1. As this distance increases, then it becomes type 3. You can see here that it could be very difficult to engage the type 3 arch or even type 2 arch because the origin of the brachiocephalic, right brachiocephalic artery is so low in such arches. And these are the aortic arch variant that is that gives the idea about the bovine arch. Here the image in the D is actually the bovine arch that we see into the cattle or in bovine animals, but it is not seen in the human. The figure of the figure that is depicted with D, but we can see commonly the B and the C. So in the B and C, you can see that the left common carotid artery and innominate artery has a single origin, arise from the one as a single trunk. So that is the bovine arch for the human. It is actually a misnomer. True bovine arch is like all entire trunk is arising from the aortic arch, and it is not seen in human. That is seen in cattle and all. That is shown in figure D. A is the normal variant of the aortic arch, whilst B and C is somewhat example of bovine arch that we see in human, but figure D is what we see in the cattle. So usually we get a femoral artery access, that is transfemoral carotid artery stenting, but transradial is also explained, and there is direct transcarotid artery revascularization, where we give a low neck incision and we open up the common carotid artery, and from directly there we access the carotid artery. So this also has been explained. The potential advantage of transcarotid revascularization is we do not traverse the aortic arch, and thus risk of atheroembolism is not seen. So peri-procedural risk of stroke or atheroembolism is less with direct transcarotid revascularization. It is done with a stent only, not like endarterectomy, but very few data is for the TCAR. Even at our institute, we mainly go with transfemoral access. So generally heparin dosage we all know. For uncomplicated anatomy like type 1 aortic arch, there is no tortuosity, no bovine arch, we go with the JR catheter. And for complicated anatomy, we can consider Siemens catheter. This is the slide about antiplatelet therapy before undergoing carotid artery stenting. So we have to give aspirin and clopidogrel in this much doses at least 48 hours, that is at least 2 to 3 days prior to the stenting. Or if one has taken up at an emergency basis, then one can give directly clopidogrel loading like 300 mg and aspirin as 325 mg and take up the patient. And aspirin and clopidogrel, both double antiplatelet, should be continued at least 4 weeks after stenting, and then thereafter based on the other diseases, or one can continue as antiplatelet monotherapy as well. So for 1 month you give dual antiplatelet, and it should be started at least 3 days prior to the stenting based on the guidelines of European Society of Vascular Surgery. So these are the certain techniques of forming the JR catheter. We know how to engage directly, but for Siemens catheter, these are the various techniques where for how to engage the carotid arteries and how to form the curve of the catheter into the ascending aorta. Like the first technique is about scissoring technique, where we make a loop, and then after when we do the clockwise rotation, it will form the catheter into ascending aorta in such a shape that it can engage the common carotid artery. The other technique is also about same. This is left subclavian technique, in which we form the catheter into left subclavian artery like this. And one can also form Siemens catheter at aortic bifurcation level only, like in this as shown in this depiction. So we form it at the level of aortic bifurcation by making it like this and engage. So same slide. After the defining the anatomy, once we have decided to put a stent or do a intervention, usually we take up the 8 French guide. So at our institute we most commonly use the JR guide as a 8 French JR guide, and it is placed into distal CCA. So how to do it is once the CCA is engaged with diagnostic catheter like JR4 or Siemens, the guide wire is advanced into CCA, and then diagnostic catheter is also advanced there. Then the wire is removed and we put a super stiff wire, so our guide would go over there with, even if there is the anatomy is tortuous. So super stiff like Amplatzer super stiff or supracore wire, such wire is placed, and then end French guide is delivered to distal CCA, and the rest of the steps are followed like that. In tortuous aortoiliac anatomy, one can consider for long sheath as well, like a flexor long sheath or destination sheath. Instead of using an 8 French guide, one can use this sheath, and we can consider through the intervention through this sheath. After this, we will discuss some about embolic protection device. For carotid artery stenting, there are 2 types of embolic protection device. One is filter type, another is proximal occlusion device. Most commonly we use filter type devices. At our institute we commonly use EmboShield. another is the spider, and the rest of the filter type device. These are the distal filter that prevent the embolization, and they are made up of polyurethane membrane. So it should be deployed in a straight portion, not much tortuous, and non-diseased segment of the cervical portion of internal carotid artery. Usually it is 30 to 40 mm from the lesion site. The disadvantage of filter is during the many of the filter, like the embo shield comes with its own guide wire, that is a bare wire, with which we cross the lesion first, then we cross the lesion with the filter, that is undeployed filter, and then we deploy the filter distally. So initially during the crossing and crossing of the filter, during this time this process is unprotected. So if there's some emboli occur at this time, then it is the cerebral circulation is not protected. There are many times it can be filter can have incomplete apposition. Sometimes filter itself can cause some vasospasm or damage to the vessel wall, and very rarely filter can it is difficult to retrieve the filter back. So these are the some disadvantage of filter. If during the procedure filter get clogged, then you have to aspirate the blood that is proximal to filter. Next is the disadvantages of the filter. So as like in ambo shield filter, the filter itself comes with a guide wire, that is a bare wire. So we first cross the lesion with this wire, then after that we cross the lesion with the undeployed filter. During this portion of the process, the cerebral circulation is unprotected, so filter itself or wire itself can cause some embolization. So that is one disadvantage. Another is incomplete apposition of the filter can lead to embolization of small material into cerebral circulation. Filter itself can cause vasospasm or damage to the carotid artery, and sometimes retrieval of the filter can also become difficult once the stent has been placed. So all filters allow at least some small particles to go through them, and the stroke can occur even after placement of the filter. But it is always recommended to use embolic protection device prior to the carotid artery intervention. Another important step is, so once the filter has been placed, if patient has some embolization, then filter will become clogged with this embolized material. So you have to use some device like export a thrombectomy aspiration device or some device to aspirate the blood, that blood which contains the embolized material, prior to retrieving the filter, and then you place one more filter, and then you consider the rest of the procedure. So these are the filter that this is how the ambo shield now looks like, that we use at our institute as well. These are the other they looks almost similar, but there are some aspect of deploying their processes of deploying them might be different, and one can see many videos on YouTube as well to look for how to use this filter and how to deploy them and how to prepare them. And this is the schematic presentation for proximal balloon occlusion device. So here the one balloon is inflated in external carotid artery, and the distal balloon is inflated in ECA, while proximal balloon is inflated in distal common carotid artery. So there will be reversal of the flow, or the flow will become stagnant across that particular segment of internal carotid artery, and you perform the procedure through this device only. Once the procedure is completed, we aspirate the remaining blood which could contain some embolized material, and then the flow is restored. But the disadvantage of proximal occlusion devices, it requires larger sheath, so access-related complication can occur, and even with the proximal occlusion, cerebral ischemia can occur, because we are completely occluding the common carotid artery with a balloon. So there is a risk of because of transient loss in the flow in internal carotid artery, there could be in up to 5 to 10% of the patient stroke or symptoms can occur of cerebral ischemia. So usually we at our institute we do not predilate the lesion. If lesion is very critical, which increases the risk of which increases the risk of even even our embolic protection device can also not go through it. Then in such cases we predilate the lesion. Otherwise we are usually avoiding predilating the lesion and we directly go with the stenting. If you consider predilating, you use the low profile coronary balloon like 3 or 4 mm, and there are multiple stent available, but in current era we only use self-expanding stent. They are made up of nitinol alloy. And there are two types, open cell or closed cell design. So just like in coronary, closed cell provide better scaffolding, so less embolization, but flexibility is less with the closed cell design. Open cell has more flexibility. There are two kind of stent. One is tapered stent and other are the straight stent. At our institute we use tapered stent because there is a mismatch in the size between internal carotid artery and common carotid artery, and we place stent in such a manner that it extends from internal carotid artery till the common carotid artery, because majority of the occlusion in internal carotid artery is at ostium of the carotid artery. So we have to put it across the bifurcation. So at our institute we commonly use AccuLink tapered stent, that is an open cell design, and it comes at a size of 6 to 8 mm or 7 to 8 mm or 8 to 10 mm, 7 to 9 mm or 8 to 10 mm size of diameter, and length is around 30 or 40 mm length. We commonly use 6, 8 to 40 mm size. Right? One can decide based on angiography. For tortuous location, open cell is better obviously because of flexibility, and for calcified lesion to yield more expansion, one can consider for closed cell design like exact. After angioplasty, we can consider post dilatation with 4 to 5 and 5.5 mm balloon. That is usually we use coronary balloon only, a non-compliant coronary balloon of 4 to 5 mm size. During this particular step, there is greatest risk of plaque embolization. Another risk is during the dilatation of the lesion or putting a stent or doing a post dilatation. There is a carotid artery. Carotid artery has carotid body and carotid receptor that can get activated, producing a vagal response, and can cause patient can undergo severe bradycardia and hypotension. So you have to be prepared for that during the procedure. Many operators also pre-hand give before even dilating, give the atropine and fluid, and then they dilate put a stent or consider for post dilatation. So this is how, as I was saying, if after putting a stent or doing a post dilatation, sometimes there is a slow flow. So this can be because of distal embolization. If such embolization occur, then one should consider aspirating up to 40 to 60 ml of blood column, that is proximal to the filter, using either a thrombectomy aspiration device or like that, and then one can also avoid post dilatation if result is adequate. In carotid artery stenting, we can leave up to 20% of residual stenosis. So if only if it is more than 20 or 30%, you consider post dilating the lesion. So this is a schematic diagram of the same. If there is a distally there is a filter. If there is some embolic debris that is clogging the filter, you can say using this export is actually thrombectomy aspiration device. Using that, they are aspirating the blood column. So what is the post-procedure care in such patient? So such patient is usually kept for 1 day in the ICU, during which the neurological and hemodynamic monitoring, frequent monitoring is must, like blood pressure. The blood pressure should be kept in the range of 120 to 130 and 82 and 70 to 80 mmHg. Not much lower blood pressure the patient can also develop the hemodynamic compromises, I have already told, because of vagal reaction. So in such patient, patient might need noradrenaline, or some patient can develop the hypertension. In such cases, we might need the antihypertensive. So patient will receive usually lifelong aspirin, and clopidogrel is given minimum for 1 week, and yearly carotid ultrasound examination should be done. So this is just a carotid artery stenting procedure has been shown in this particular slide. What are the complications? So we have excess site complication like local hematoma and RPH and pseudoaneurysm formation like that. We can have catheter related complication like embolization, TIA or stroke, and we can have a treatment related complication like spasm or dissection of the carotid artery, thrombosis, or dislodgement of material during the filter retrieval or embolization. So most important complication of this procedure is stroke. So stroke can occur in up to 2 to 6% of the cases, but as I have in recent year it has been decreased with the use of embolic protection devices and all. These are the 30-day incidence of the stroke, that is 2 to 4% in the recent years. And for asymptomatic patient, if the stroke risk is less than 3%, then only we take up the procedure. And for symptomatic patient, it should be less than 6%. Majority of stroke are ipsilateral. Many of them are ischemic stroke, but the patient can also develop hemorrhagic stroke. Mostly they occur at the time of the procedure or within the 30 days, but mostly in the perioperative period. So they are due to distal embolization, but hemorrhagic stroke are also explained because of cerebral hyperperfusion that we will discuss in next slide. During the procedure, one can develop hemodynamic compromise, as I have already told, because of baroreceptor, carotid receptor activation. There is because of pressure due to the stent or due to the post-dilating balloon, one can develop hypotension with low systolic blood pressure and severe bradycardia. In such patient, it is important to immediately intervene using either IV fluid or using the atropine. Many operator prior to the particular stent implantation or post dilatation give atropine at least for to prevent the hemodynamic compromise. So what is hyperperfusion syndrome? It is rare, it occurs in less than 1% of the cases, but hyperperfusion occur because once there was a chronically ischemic cerebral artery, cerebral territory. Our carotid artery is chronically occluded, and now you have opened it up. So there is significant increase in the cerebral blood flow. This increase in the cerebral blood flow occur in the face of impaired cerebral autoregulation, and this can result in transudation of the fluid into the cerebral parenchyma, which can cause cerebral edema, which will present as ipsilateral headache, throbbing, vomiting, and all the signs of raised ascity. Eventually, patient can even develop intracranial hemorrhage. In such cases, mortality exceeds 40 to 60%. So these cases mostly occur within the 24 hours, but some risk can still occur up to 30 days with some risk. So the antihypertensive that increases cerebral blood flow, that vasodilate the vessel, are actually contraindicated, like nitroglycerin, nitroprusside. They should be avoided as much as possible. And recommended agent to treat the hypertension in these cases are beta blockers, labetalol, or one can use clonidine. Neuroimaging is a must to rule out the hemorrhage. And risk factor for developing the cerebral hyperperfusion is perioperative uncontrolled hypertension, or post-procedural hypertension, or if there is a contralateral carotid artery occlusion as well. So if you open up this artery, there is already the cerebral circulation is already chronically ischemic, and now with the opened artery, there is a increased cerebral blood flow, which can result in cerebral hyperperfusion. But fortunately, this is very rare complication, occurring into 1 to 2% of the cases. Instant restenosis is late and very rare complication. So these are some evidence for carotid artery stenting versus carotid endarterectomy. So most noted trial are the Sapphire trial and the CREST trial, which was done in the most the symptomatic patient as well as the asymptomatic patient. In these trials, they have seen that the risk of stroke and periprocedural death within the 30 days is lesser with carotid endarterectomy compared to carotid artery stenting. So it is less with carotid endarterectomy, but risk of MI, risk of myocardial infarction or ACS is more with the carotid endarterectomy. But this is for the general patient, not for the post coronary, for the patient who is undergoing coronary artery bypass, or those who have the critical left main disease, triple vessel disease, or severe LV dysfunction. Such patients are usually excluded from these trials. These are for the general population. So there are no randomized control trial in coronary artery in a patient who is undergoing coronary artery bypass for comparing the carotid artery stenting versus CEA. So, and majority of the data that is non-randomized is showing that carotid artery stenting might be better in such patients. Recently, there is one trial that is published into NEJM, that is CREST-2 trial. In this trial, they have two arms, that is carotid artery stenting arm and carotid endarterectomy arm, and both these arms were not compared with, they were compared with medical management. So in these patients, those who underwent the stenting procedure has less risk of the 4-year event, like 2.8%, while the risk of endarterectomy arm had almost 4% risk of 4-year event rate. So in this trial, they showed that the stenting significantly reduced the risk. This is the recent addition in this trial. So we will conclude our talk with this. Thank you very much. Thanks.